I appreciate it's a Sunday and it's a little bit late. That's my fault. I just had some technical difficulties. Really sorry about that. But maybe we should get started. I don't want to waste people's evenings. So obviously today we're going to be talking about hematology for people who I haven't met yet, which I think is a lot of you. I'm Frances. I'm one of the G3 / year 5s. So obviously was in your shoes last year. And obviously, big shoes to fill. Debbie Hay is a fantastic lecturer. I don't claim to be anywhere near as knowledgeable or fantastic as she is. But that being said, hopefully we can cover the content that you guys really need to know to help you pass the exam. And yeah, I think it's a really interesting topic. So hopefully, we can try and make it interactive if people want that. If you prefer it not to be interactive and you just want me to give you the high yield info, I'm totally fine with that as well. So I will just tailor it uh, depending on how you guys respond. Obviously, there will be some questions right at the end, like some Socrative questions, just to kind of test some of the concepts. And I think I've got a couple other questions that I saved up for you guys that I can send when I send out the slides with answers and explanations. So hopefully a lot of opportunity to practice. I will say that hematology, so this is your syllabus. And I think that in general, Debbie does have quite high expectations of people. So I think that her questions do tend to be a little bit more of the tricky ones in the formative and also in the real exam. And what I mean by that is not necessarily the content is super hard, just that the reasoning is maybe a bit more than there are in some of the other things where you can just memorize keywords. So I do think having a good understanding will really get you guys quite far. Obviously going to try cover pretty much all of this today in the next sort of hour and a half. So please do chip in, tell me if I am going too fast, too slow, if you think it's too basic or anything like that. I'm happy to adjust for you guys. I'm not 100% convinced if I can see the chat or not, but hopefully I will if you guys pop anything in there. Otherwise, just raise your hand or feel free to unmute. I'm very happy to be interrupted at any stage. Okay, so let's get going. So let me just see if I can minimize this. All right. So the main thing is that basically controls all of hematology is the process of hematopoiesis. So this is all really happening in the bone marrow in the adult. And this is talking about the generation of all of the different blood cell components. So when we talk about blood cells, we're talking about all of the red cells, the white cells, the platelets, and so on that are circulating in the normal blood volume. This all begins in the developing yolk sac around 3 weeks of gestation, and it gradually moves to different locations through the process of fetal development. So the hematopoietic stem cells will move to the fetal liver by around 6 weeks gestation. They'll seed a bit to the spleen as well, and hematopoiesis will continue in those locations almost until birth. And then by birth, all of that is happening within the bone marrow of your central skeleton by the time you're an adult, but as a kid, pretty much all over the body. So key other definitions that you want to know is that myeloid is basically referring to cells of the marrow. So we're talking about all of the red cells, platelets, and granulocytes and their precursor cells. And there is a bit in your syllabus about trying to understand what the role of these different cells is. I think you guys mostly know this, but obviously immunity, clotting, and so on. The lymphoid cells are really your B and T lymphocytes and the plasma cells, as well as their precursors. So that's responsible for your adaptive immune system. Erythroid just refers to red blood cells. So erythrocyte, basically. And reticulocytes are the immature erythrocytes. So they're nucleated and they're polychromatic. And they will gradually lose their nucleus as they mature to a fully mature red blood cell. Okay. So this is basically the entire process illustrated for you. It's really not that necessary to know all of the names of all of the different sections. In fact, this is a very simplified diagram. There's many more levels that are involved in this process. But what you need to know is you start off with this multipotent hematopoietic stem cell that's in the bone marrow, or it should be. And then you basically either decide whether you're going to be a myeloid cell and give rise to all of these cells, or you become a lymphoid cell and you're going to be giving rise to these cells. And from there, you basically will give rise to your various different cells, and they will then be specified in their own differentiation process. So erythropoiesis is one of the developmental stages that's really important to understand. So this is the generation of red blood cells. Again, you do not need to know these names of all of these different stages. What you need to know is you start with a common myeloid progenitor and you end with an erythrocyte, which is your red blood cell. And in that process, as I said, you give rise to a reticulocyte, this nucleated red blood cell that's going to lose its nucleus and it's going to become more condensed and form a red blood cell. So this is really happening sort of within the blood. So you have like around 1% or 1.5% reticulocytes within your blood normally, just through the natural process of erythropoiesis. But that reticulocyte count is really giving you a good estimate of how much blood cell production is happening within the bone marrow. So you know that your bone marrow is active if you have reticulocytes present in the blood. So that's why we care about the reticulocytes. And of course, as you guys know, this process is controlled by the hormone erythropoietin, which is produced in the kidney. So you have interstitial cells in the kidney that's role is to produce erythropoietin. And that production is all based on sensing of hypoxia. So essentially, you sense a drop in oxygen, i.e. a drop in oxygen from the blood that's coming to the kidney. And as a result, you'll produce more erythropoietin, which will go to the bone marrow and stimulate the myeloid cell production, and then eventually erythrocyte production as well. So this is basically roughly the feedback loop that is happening. So you essentially have your hypoxia detected within the kidney, and that's via the HIF pathway. You don't need to know the specifics of that, but it's useful to know that, you know, HIF is obviously critical to this process, as is the von Hippel-Lindau ubiquitin ligase. So that can be useful to know. This will increase EPO synthesis, and then eventually you increase your red cell synthesis in the marrow. And that will allow you to have more oxygen carrying capacity in your circulation as well. And this is basically a negative feedback loop. So once you have increased oxygen capacity, you no longer need to produce as much EPO and so on. But of course, with any sort of feedback loop, there are different levels at which this could go wrong. And I've just kind of given you some examples of the kinds of things that we're talking about. So if you know this feedback loop pretty well, it's very easy to even hypothesize how things might be disrupted. So obviously, you know, if you don't produce enough EPO, maybe because you have chronic renal disease, and so you're not able to produce the EPO, then you're going to end up with anemia. As well, if you lack the components to make red blood cell synthesis, to make red blood cells, irrespective of whether you get EPO, you're still going to be unable to produce those blood cells. So that's things like your hematinic deficiencies, like iron, B12, folate. Also, if your bone marrow is just being destructed by cancer, so for instance in myeloma, and if you have something like an aplastic anemia, where essentially all of your blasts are being wiped out. And then at the same point, you might make red blood cells, but they might be defective. So that's the process of ineffective erythropoiesis that you see in things like thalassemia and myelodysplastic syndromes. We're going to be coming to each of these, so please don't feel this is the only knowledge that we're going to cover today. So we're going to come back. And of course, you could just produce your red blood cells and then they're all lost way too soon. And then you end up with insufficient red blood cells for oxygenation. And again, that's like in a hemorrhage situation when you have a lot of hemolysis occurring as well. So this leads us to anemia, which is basically when you don't have enough red blood cells and hemoglobin to adequately oxygenate your tissues. So your normal range kind of hemoglobin varies between males and females. As you can see here, normally they're giving you all of the normal ranges in the exam, so you don't really need to worry about this. But in my experience, when you get to clinical placement, it's useful to have a rough gauge of what these values might be just to follow conversations and things like that. Um, Anyway, the symptoms of anemia are more things like shortness of breath, fatigue, dizziness or syncope, palpitations, and angina. So you can kind of reason your way through this. Obviously, if you're not, able to oxygenate your tissues, your organs can't function as well as they could, and so you get sort of symptoms and signs of ischemia. As you can see here. And then obviously patients often present with conjunctival pallor as well as tachycardia, which is a compensatory response. So you're trying to pump your blood around faster so that you can oxygenate your tissues. And with anemia, what we're doing is we're splitting this into microcytic, normocytic, and macrocytic based on the mean cell volume of your red blood cells. So basically how big the red blood cells are. And if you know the MCV, it really helps you to narrow down what could be causing the anemia in the first place. And anemia itself is not an adequate diagnosis. You always need to try and figure out what is causing the anemia so that you can treat it appropriately. So I found this to be quite a helpful diagram when trying to sort of picture what the different causes of anemia could be and how they might present in terms of MCV. So essentially on the microcytic end, when you're very microcytic, you're thinking of things like thalassemia, where the red blood cells are really, really small, and iron deficiency as well, which is the most common cause of microcytic anemia. When you're on the macrocytic side of the spectrum, you're thinking more about B12 and folate, especially if that MCV is really, really high. But it could also be things like chronic liver disease, hypothyroidism, and so on. And then when we're talking about normocytic, that could be anemia of chronic disease, or when you're hemorrhaging, or you have a hemolytic picture that's occurring as well. So we'll kind of break these down so you guys understand the pathophysiology a bit better. So starting with the microcytic side of things, this is basically when your MCV is less than 80. So your red blood cells are a lot smaller than you would expect them to be according to normal range. And typically this is because you just have reduced hemoglobin available. And the most common cause by far is iron deficiency. So essentially this could be due to several different things. So when you think of sort of any kind of hematinic deficiency, you can kind of split it into whether you're just not taking in enough iron in the first place. So maybe that's because you have a vegetarian or a vegan diet where you're not ingesting enough of the heme iron that you need. It could also be that you just have an increased demand for iron. So for instance, if you're pregnant, you need a lot more iron than if you're not. So that could be one thing. Or also when you're a child, because you're rapidly growing, you might need more iron as well. It could be that you're just not absorbing it. So maybe you're eating it, but you're just not able to take it in. And that could be because of celiac disease. So I think you guys might have had the GI revision lecture, but as you know, iron is absorbed in the duodenum. And the celiac disease typically is affecting the small bowel quite significantly, and that prevents you from taking up iron. And then also things like, again, a chronic kidney disease could also essentially block iron absorption. So that might be another mechanism by which you're not absorbing enough iron. It could also be because of blood loss, and this one's quite important. So obviously this could be in the case of young premenopausal women where it might just be a menorrhagia picture. Obviously that's something that we could definitely address with medication. So we do want to try and treat that. But the more concerning thing perhaps is about GI bleeds, especially in elderly men. So that's when you really need to start referring your patients down 2-week weight referral pathway, doing a fit test, and making sure that there's no lower GI bleed that's causing the iron deficiency. So to investigate this, you want to be looking at your blood count. You obviously diagnose the anemia part with low hemoglobin and the microcytic part with the low MCV. Low MCH will also be there. So the cells will be hypochromic. So they're just paler than normal. You do your set of iron studies. And if you see low ferritin, which means low iron stores, that is essentially diagnostic of iron deficiency anemia. And then you need to look for underlying causes. If you did a blood film, which I will say we don't typically do for just a standard microcytic anemia, but if you did one, you might see target cells, which there's a picture of here. So they basically just have like a bullseye target in the middle. Also, sometimes you get pencil-shaped cells, which are sort of kind of like this, more pencil-shaped. You also get poikilocytosis and anisocytosis, so variation in the size and the shape of the red blood cells, basically. And then if you're looking for your underlying causes, GI bleed, as we said, a FIT test, you want to pick up any hemoglobin that's basically being excreted in the feces as a result of a GI bleed, a lower GI bleed. And celiac disease, you would order your tissue transglutaminase antibody and anti-endomysial antibodies panel as well to try and look for that. And ultimately, you just manage the iron deficiency part with iron supplementation, as you might expect. The other cause of microcytic anemia that you need to know is thalassemia. So this is what's known as a quantitative defect in your globin chain synthesis. So you basically end up with an imbalance between the alpha and the beta globin chains. And this means that your excess chains, either alpha or beta, basically will aggregate together and they cause damage to the cell membrane. And what this means is that when your red blood cells are developing in the bone marrow, they're actually being, some of them will be killed earlier on because they're just not healthy. And so this is kind of ineffective erythropoiesis, so ineffective blood cell production as a result of the fact that the membrane is damaged. Yeah. So this can be either alpha thalassemia or beta thalassemia. As you guys may recall from preclin, your hemoglobin molecule is made up of alpha globin and beta globin. So a standard adult hemoglobin would be alpha 2, beta 2. And that's what we call HbA, if you guys, or HbA1. And so that's what you would normally expect. But in alpha thalassemia, you would have too few alpha chains, and that means you have a beta excess. And in beta thalassemia, you'd have too few beta chains and you'd have an alpha chain excess. And so in terms of the investigations, what you would see is just a very, very low MCV. As I showed you earlier, this tends to be even lower than we would see with an iron deficiency picture. Again, the cells are hyperchromic because they do not have enough hemoglobin. Again, so that's the reason for them being quite pale. You also get those target cells. And ultimately, the diagnostic test that you really want to order is a high-performance liquid chromatography or genetic sequencing, but that wouldn't be as widely available or as cheap to do. So you want to order this HPLC basically to look at the different peaks of hemoglobin that you have, and that's going to help you reach a diagnosis. And I'm going to come on to how you reach that diagnosis in a second. So management would be transfusions if they are symptomatic enough to need that. And these patients are really, really significantly at risk of iron overload because you can imagine they don't have a problem with iron absorption. So they're still trying to take up as much iron as possible to increase your blood cell numbers. But these cannot be incorporated appropriately into the hemoglobin molecules. And then as a result, you end up with just a lot of iron deposition. And that can be quite that can cause quite a lot of issues in various organs across the body. So we want to give them iron chelators as well. And that typically is the case even if they are not necessarily needing transfusions all the time. So just some keywords here for what you might look out for in a question stem as well. So to summarize the thalassemia, this is kind of the best way that I found to illustrate the different categories and what you might get in a question stem. So I've just put here the alpha globin gene that you find on chromosome 16 and the beta globin one. And the only thing I want you to see is that essentially there's two alpha globin genes on each chromosome. So you end up with 4 alpha globin genes, whereas beta, you only have 1 per chromosome. So you have 2 genes in total, basically, or 2 alleles. And so what that means is that a lot more can go wrong if you have a lot of alpha missing, whereas beta, you can kind of compensate because you have this delta globin as well. So essentially, when we talk about thalassemia, the old terminology for this is split into thalassemia minor or thalassemia trait, thalassemia intermedia, and thalassemia major. This is kind of changing now. So they're mostly referring to this as sort of thalassemia trait and then non-transfusion dependent and transfusion dependent thalassemia. So I've kind of tried to list that here so you know which is which. But when we talk about alpha, if it's a thalassemia trait, what that means is you're essentially missing only one alpha gene. So you have three other functioning ones, or you might have one alpha gene per chromosome and you're missing two. Or you just have you have an entire chromosome that has no alpha, but on the other one you do have both copies. So in this case, these patients are quite asymptomatic. They have mild anemia, and this is really hard to diagnose via HPLC because it's going to probably be normal because you can still produce your normal hemoglobin. It's just that the relative proportion of hemoglobin that you're producing is lower, but everything will be lower, if you know what I mean, because alpha is involved in all of the hemoglobin molecules. So this won't really show any significant abnormality, but you will still have a microcytic picture and so on. If they have thalassemia intermedia, alpha thalassemia intermedia, this is what we call HBH disease. So it's just because this hemoglobin molecule that's produced is called HBH as instead of like HbA, for instance. And that is when they just have a single copy of the alpha globin gene. And this is, again, non-transfusion dependent. They can compensate quite well for this. But if you have no alpha globin genes at all, this is basically incompatible with life because, as I said, you need alpha globin for all of your hemoglobin production. So there's really not. I think there has been recorded cases that people have lived, but this is extremely, extremely rare. Normally, they're dying in utero, which is Bart's hydrops fetalis, essentially. The beta spectrum, I think this comes up a lot more commonly in exams because it's got a lot more nuance to it that you can easily test by looking at the HPLC results, which they'll normally give you. So essentially, if it's a thalassemia trait, this means that they have either beta plus beta or beta naught beta. So beta naught means they're not producing any globin gene on that chromosome. So that would be they basically only have one. Whereas beta plus means they're producing some beta, but not as much as they normally should, if that makes sense. So this could be a problem with sort of the amount that's being produced, sorry. And in this case, this is again usually asymptomatic. They have mild anemia, but you would probably see some changes on the HPLC because you could normally see a slight rise in your HbA2, which is your alpha 2 delta 2, so that's when the delta 1 is compensating. So this will also have raised HbA2. Sorry, I didn't put that here. Then in thalassemia intermedia, this is when you get beta plus beta plus. So essentially you have some being made on both, but it's just not enough. And again, this will give you a raised HbA2 with reduced normal hemoglobin, and it's non-transfusion dependent. So they don't typically need transfusions unless they have, a specific reason where they're losing a bit more blood than normal. And then thalassemia major is when you essentially don't really have any beta globin that's being produced or very little. And here your HbA2 is going to be very, very high. You'll probably have some fetal hemoglobin that's coming up as well. You normally have like 1% fetal hemoglobin in adulthood, but this will be much higher. And you won't have any normal hemoglobin A at all. So this is transfusion dependent, and it's normally around like every 2 to 4 weeks they come in for a blood transfusion. So I hope that all makes sense, but hopefully there'll be a question in Socrative later so we can go through that a bit more if needed. The final cause of microcytic anemia, this is kind of small print, I would say, but sideroblastic anemia, this is essentially when you have enough iron, but you're just not incorporating it into your hemoglobin properly. And that might be for congenital reasons or acquired through alcohol or lead or drugs, things like that, which can interfere with that process. And essentially what you'll see is on the blood film, you get these ringed sideroblasts, which is basically where you get a nucleated red blood cell, but they have a ring of iron around the nucleus. Sorry, I don't know if you guys can actually see my pointer. I hadn't put that there. And essentially what you would do is stop any drugs that might be causing it, if you identify any, and then you can give transfusions and also pyridoxine. So moving on to macrocytic anemia now. This is when your MCV is greater than 100. And this is normally due to either B12 or folate deficiency. Those are some of the most common causes. And again, with B12 being another hematinic, it could be similar reasons to iron. So you're just not taking enough in, maybe because you're because of malnutrition or because you're vegetarian, for instance, since B12 is predominantly found in animal and dairy products. Maybe because you're not absorbing it. So B12 has to be bound to intrinsic factor, which is normally happening sort of in the stomach. So you need to essentially have intrinsic factor present. So that's why pernicious anemia, where you have autoimmune destruction of intrinsic factor, can cause poor absorption. Celiac disease can cause poor absorption, IBD as well, and pancreatic disease. So pancreatic disease, I think this is less intuitive, but it's basically to do with the fact that you'll have reduced pancreatic enzymes, and the pancreatic enzymes are really important, again, for this B12 intrinsic factor binding. I think it gets transported from one other molecule to intrinsic factor in the small intestine. So that's basically what happens. Drug induced, so nitrous oxide. So essentially recreational drug use and things can cause B12 deficiency. You might have increased demand, again, if you're pregnant and things like that. So symptoms and signs to look out for: glossitis, which is really this kind of quite a significantly enlarged tongue, peripheral neuropathy, so sort of paresthesia in the peripheries, and then sort of any signs and symptoms of subacute combined degeneration of the spinal cord, which is due to the fact that B12 is really needed for myelin maintenance. And so you lose your dorsal columns. And this is obviously very, very severe. And if it if it's not caught early, it's basically irreversible. So you really want to try and detect this early on. So we want to try and pick up B12 deficiency, and we can do that by looking at the MCVs. It should be high. If you did a blood film, you see these hypersegmented neutrophils on the blood film. That's quite characteristic of B12 or folate deficiency. Those kind of the only things that are going to give you this picture. Decreased serum B12 levels. Although I should say, and I've got this in the slides on the notes, B12 levels can be a little bit tricky to interpret because there's a lot of things that can kind of alter what B12 is bound to. And so some of it might be present, but it won't be available to use, even though it's in the circulation. So things like pregnancy, oral contraceptives, and things like that can affect your B12 levels, and sometimes they can make them falsely low or falsely reassuring. So you just want to watch out for that. If you need, you can also more directly measure things like methylmalonic acid and homocysteine, which are basically the substrates that require B12. So they will build up essentially, and that can help you figure out if there's low B12. And then you'll also get this megaloblastic change in the bone marrow. Management is either intramuscular or oral B12 replacement. Obviously, if they have pernicious anemia, you're probably having to do an intramuscular injection. So obviously it depends on what the causative reason for their deficiency is. Then folate deficiency, again, similar things, low intake, could be hemolysis. So folate stores are they're quite reduced. So they will be, folate specifically out of all the hematinics will be used up really, really quickly in a hemolytic picture. So you typically always need to give folic acid supplementation to patients who are presenting with hemolytic anemias. Poor absorption because of celiac disease. Antifolate medications, so things like methotrexate, as well as your anti-epileptics, and increased demand like pregnancy. Remember, folate, we need to encourage pregnant women to supplement with folate, particularly pre-conception, really, and in the first trimester, because of the risk of neural tube defects. So that's really, really important. Again, this will present with the high MCV and the hypersegmented neutrophils on the blood film, and you'll see a decrease in your serum folate levels. Management with folate replacement, but the key small print here is that you must always, always, always replace B12 before you replace folate. And they actually do this pretty much always, even if there's no specific B12 deficiency that's been identified. And the reason for that is because, as you can see, the investigations show very similar results. And if you replace folate, you might start to see an improvement in your hemoglobin, which will reassure you that there is no B12 problem. But actually, the B12 problem might just be being masked by the increased folate that's been available, and then you end up with subacute combined degeneration of the cord. So that's the reason why you must always replace B12 first when you're replacing folate. Yeah, ideally you would have the diagnosis of both, but that's just something to bear in mind. Then you can also have non-megaloblastic macrocytic anemias. So there is different reasons for these. So things like alcohol excess, which you would see a rise in your GGT, or you'd see deranged clotting because of the effects on the liver. Liver disease, again, you want to do your liver function tests and your clotting tests. Hypothyroidism, you can check your thyroid function tests. Myelodysplastic syndrome, which I'm going to come to, but essentially for this, you can do a blood film and a bone marrow biopsy, and congenital causes as well. So that's macrocytic and microcytic. Now on to normocytic. So this is when you have a low hemoglobin, but your MCV is normal. So it's within 80 to 100, which is normal range. And in this case, what you really want to look at to try and figure out what's going on is your reticulocyte count. And the reason being is because if you're losing blood or you are hemolyzing, you should see that the reticulocyte count goes up. So it will be more than 3%, because essentially you have this compensatory response by the bone marrow to try and produce as many red blood cells as possible. So that's why that should increase. The decreased production of less than 3%, but often it'll be less than 1.5%. So this can kind of help you narrow down your reasons for normocytic anemia. So just to go through the different causes of this, it could be a hemorrhagic situation, so an acute hemorrhage where you're losing a lot of blood. To be honest, in this situation, your hemoglobin's probably going to come back as normal if it's very, very acute, just because you're losing a lot of blood, but it hasn't really sort of diluted down. So you wouldn't know that your hemoglobin is going down, if that makes sense. But over time that would become anemic and it would be normocytic because there's nothing wrong with your red blood cells, there's just less of them. Chronic blood loss as well. So this is like your GI bleeds and things like that, can originally can cause a hemorrhagic picture, but this tends to be a microcytic anemia because the iron would be depleted. So it might start as normocytic and then gradually progress into a microcytic picture. And that's how iron deficiency anemia starts as well. So it tends to be normocytic and then gradually becomes microcytic because it takes time for all of the red blood cells to show that change. So obviously stop the bleed and transfuse as quickly as possible. Other causes is hemolysis. So in hemolysis, you will see a raised reticulocyte count in that compensatory response. And when we're talking about hemolysis, I think it's useful to try and remember the difference between hemolysis and ineffective erythropoiesis. So hemolysis, the red blood cells are being destructed, but this is happening once they've left the bone marrow. So these are in the circulation essentially, or basically outside of the bone marrow, because it can be extravascular as well. Whereas ineffective erythropoiesis is more to do with the fact that there is a problem with the red blood cells as they're being produced in the thalassemia picture. So those are kind of separate mechanisms. And in that case, those early red blood cells and red blood cell precursors are being destructed sort of in the bone marrow, so it doesn't present with the same sort of features. So as I said, hemolysis can be extravascular or intravascular. If it's extravascular, this is typically happening in the spleen, so outside the circulation. So as the red blood cells are being filtered through the spleen, they're kind of getting trapped there for various reasons or destructed early, maybe because they're already abnormal. And in that case, you would see spherocytes on the blood film. So these are just much rounder red blood cells, and this is because the splenic macrophages are basically taking chunks out of the red blood cell membrane as they pass through the splenic architecture. In this case, your lactate dehydrogenase does rise, but not as significant as intravascular. I'll come on to why. And you will still have serum haptoglobin levels present in your blood, because haptoglobin is binding free hemoglobin, and in this case, the cells are being destructed in the spleen, so there's no free hemoglobin in the blood. It's all kind of stored away. And so as a result, you won't have blood being filtered through the kidneys, and so you won't really have hemoglobinuria or hemosideриnuria. Intravascular hemolysis happens in the circulation. And in this case, you're normally seeing things like the schistocytes on the blood film. These are these kind of quite distorted red blood cells. They're kind of literally red cell fragments, essentially. They're being completely broken apart. And in this case, your LDH is really, really high because the red blood cell contents are being spilled straight into the blood. You're going to have pretty much no serum haptoglobin, or very low, because it's going to bind all of the free hemoglobin that's leaking out. And you will see a lot of hemoglobin and hemosiderin in the urine, just because it's all being filtered through the kidneys as well. And the causes are really congenital or acquired. So I think the congenital causes are maybe, especially the top ones, are maybe a little bit more small print. I would say you're probably only going to see 1 or 2 MCQs max on this, I would hope. But essentially, just to kind of cover all bases, this can be due to several problems that arise with the red blood cells. So things like hereditary spherocytosis, which tends to be autosomal dominant. And this is essentially a problem with your cytoskeleton that's normally attaching your basically your phospholipid bilayer to your inner red cell components. And as a result, essentially, you kind of get these the red blood cells kind of have these vesicular bits that come out of the membrane, and it just makes them a lot more spherical, if that makes sense. So that's why you see spherocytes on the blood film. And this is typically diagnosed with something called an EMA binding test, which is basically just binding to the various different red blood cell protein components in the membrane. So you'll just see reduced binding in this condition, I think. But you don't need to know too much about the specifics, just that that's how you would diagnose it. Management, as I said, with hemolytic anemias, folic acid supplementation is really important. And you can also consider a splenectomy if there's a very severe if there is a very severe picture, because essentially the spherocytes can't pass very easily through the splenic architecture. And so you're getting a lot of spherocytes that are trapped there. And that's a lot of your red blood cells. So effectively, you're getting a lot more extravascular hemolysis in some patients. In that case, you could consider removing the spleen, though that comes with its own risk profile as well. Then G6PD deficiency is X-linked. This is much more common in malaria areas because it's thought to provide some protection against malaria. So things like patients who come from sort of West Africa or Mediterranean areas. In this case, you're going to see these Heinz bodies on the blood film, which are basically these sort of like bits of precipitated hemoglobin within the red blood cell itself. You would then also you can either measure your enzyme levels directly, but this isn't a perfect test because the enzyme levels are going to be increased in a reticulocyte, which has a nucleus and has some RNA in it. And so because they're increased in reticulocytes and reticulocytes are increased in hemolysis, you might find that your level is actually reassuring, which is obviously incorrect. So this is why this is not great. You can also just test the reducing power of your red blood cells, because remember that glucose 6-phosphate dehydrogenase is involved in basically reducing oxidative agents. So you can test this sort of in a dish, or you could just more simply sequence the gene, which obviously in more affluent areas we are able to do, thankfully. So management is, again, folic acid supplementation, and you just want to advise your patients to avoid oxidative stresses, so things like fava beans and so on, as some common known ones. And then sickle cell disease is the one that I think you really should know. And this case, this is a qualitative globin defect. So there's qualitative and quantitative globin defects. We've talked about the quantitative globin defect, which is thalassemia, right? So that's when you have an imbalance in the number of each type of globin chain. But sickle cell disease is a qualitative globin defect, which means that there is a problem with the globin chain itself, i.e., it is abnormal. So it's an autosomal recessive condition caused by mutation in beta globin. And so you end up with essentially it's a single amino acid switch, I think glutamic acid to valine. And then the hemoglobin molecules basically are going to precipitate out in the in the deoxygenated state, producing these very rigid sickle cells. So that's the main issue because it causes these vaso-occlusive crises as the red blood cells in areas of hypoxia become really, really rigid because of all of this hemoglobin precipitation, and that then blocks up the organs and causes further ischemia as well. And so these patients, although with a lot of hemolytic anemias, you see an enlarged spleen. With sickle cell patients, it's really, really much more common to see sort of no spleen at all. They have what's known as an autosplenectomy. So all of the infarcts that are caused by the rigid red blood cells basically destructs the spleen. And so they actually really need a lot of vaccinations against encapsulated bacteria and things, which hopefully is covered in your microbiology revision lecture. And they often get pigment gallstones from all of that hemoglobin. So obviously you'll see these sickle cells on blood film. You can diagnose it with something called a sickle solubility test. You can also do your HPLC. And in that case, if you have a patient who's a sickle cell carrier, then they will have both HbA, which is normal hemoglobin, and HbS, which is the sickle hemoglobin. But if they are a homozygote, so they have full sickle cell disease, then they will have HbS and no HbA on HPLC. Okay, so those are the congenital causes. Then the acquired causes are going to be split into sort of autoimmune, alloimmune, and non-immune causes. So the autoimmune causes is kind of one of the big umbrellas, and this can be split into the warm and the cold autoimmune hemolytic anemias. So the difference is really just the type of antibody that's causing it. So in warm, it's an IgG antibody. And these will coat your red blood cells and basically mean that they are phagocytosed by the splenic macrophages. So again, it's an extravascular hemolysis. And this is typically sort of idiopathic. We can't really figure out why it's happening, or it might happen in association with autoimmune diseases like lupus or other lymphoproliferative diseases like lymphoma, or when you have drugs like penicillins that can act as haptens and basically trigger this process. So you see spherocytes on the blood film, as you do with all extravascular hemolysis, and you will find a positive direct antiglobulin test or direct Coombs test, as it's sometimes called, which I'll go through in a minute. Then for the cold autoimmune hemolytic anemias, these are driven by IgM antibodies, which you might remember are these large pentameric antibodies. So as a result, they coat red blood cells in the peripheries, or sort of anywhere, but specifically in the peripheries because it's cooler there. And this will cause red cell agglutination. So they'll all clump together and make sort of one big mesh. And it will also cause a lot of complement activation, which will contribute. And that will ultimately result in an intravascular hemolysis. So it's happening in the circulation. And for these ones, the main things is that you need to know it's associated with lymphoma and infections like mycoplasma. And you would just see basically agglutinated red blood cells when you look at your blood film. And again, you'd have your positive direct antiglobulin test. So just to kind of summarize, I just thought this might be useful for you guys to have for your revision. But it might be useful to just know a little bit about the direct Coombs test and what it's actually looking at. So essentially, you're just taking some of the patient's blood and you're washing it, so you get rid of any of the free sort of antibodies that are surrounding it. And then you're adding in your Coombs reagent, which is anti-human IgG, and it will basically bind to your antibodies that are present, the FC portion. And then you'll basically get agglutination, which would be a positive result. Then, so those are the autoimmune causes. The alloimmune causes are basically those where essentially you have antibodies that are coming from a source that's not self. So you can think of these in like the case of hemolytic disease of the fetus and newborn. And in this case, it's caused by IgG antibodies that are being directed against rhesus. So essentially, when you have a rhesus negative mother and she's carrying a rhesus positive fetus, at that time, there's not really much fetal maternal blood mixing. So everything will be fine in the first pregnancy, typically speaking. But, during birth or maybe during the process, you might have some bleeding coming from the placenta, and that will result in a bit of blood mixing. And when she's exposed to the rhesus positive cells, blood cells of the fetus, if the fetus is indeed rhesus positive, she will generate IgG antibodies against it, and that will sensitize her. And so in her second pregnancy, if she happens to carry another rhesus positive fetus, these IgG antibodies can cross the placenta, and when they do so, they will obviously cause hemolysis within the fetus and obviously fetal demise. So we do make sure that we always give pregnant mothers that are rhesus negative anti-D prophylaxis until we know, or if we don't know whether she's carrying a rhesus positive child or not. And the idea of that is basically, I think this is actually a very confusing principle. I think a lot of people think anti-D prophylaxis is preventing you from making antibodies, but it's not really doing that. What it's doing is when you are already starting to make those antibodies, the anti-D basically binds to the antibodies that the mother's making and clears them from the circulation. So they're like antibodies against antibodies that get rid of the antibodies, if that makes sense. And they last for like 12 weeks or something. So the mother's protected for like a fair amount of time. And then you can just top it up again. Okay, so non-immune causes are perhaps a bit more straightforward in the sense that you have things like mechanical hemolysis, which is basically where you have some kind of mechanical factor, be that a metallic heart valve, that's essentially beating against the red blood cells and literally breaking them apart. So that's like heart valve hemolysis. Or you can see this in like ultramarathon runners. You get something called like march or foot strike hemolysis, where essentially the foot hitting the ground repetitively breaks open those red blood cells. And then the other big group here that you really need to know are the microangiopathic hemolytic anemias, where you're essentially getting microvascular damage that's resulting in hemolysis. I'm going to come on to that. And then you have other things like infections, malaria, which you guys might know is sometimes called black water fever because of all the hemolysis that's occurring. The red blood cells are burst open by the parasite. Severe burns can cause hemolytic anemia, and also drugs and things like that as well. So the microangiopathic hemolytic anemias are a pretty big topic that comes up quite a lot, and I'm going to cover it in a few separate areas of this talk. But this is typically an intravascular hemolysis. So what's happening is that you're getting the endothelial layer of your blood vessels damaged, and this means that you end up with a lot of fibrin deposition, platelet aggregation, and then you can imagine those fibrin strands are essentially forming this mesh, and then the red blood cells are being squeezed through this fibrin mesh when they're trying to move through the small vessels. And what that means is they just basically get torn apart. So they get destructed as they try and pass through those areas. And so this is going to present like, most hemolytic anemias, intravascular hemolytic anemias with a raised unconjugated bilirubin, raised LDH. But the key thing here is that you find these schistocytes on the blood film, those red cell fragments, and you might see fibrin strands as well. Typically speaking, there are a different number of causes of these MAHA. So you really want to try and figure out what the cause is, but the patients do tend to be quite unwell. So it can cause a lot of thrombosis, purpura, bleeding, and renal failure because obviously you have issues with your circulation. So you can investigate again with blood count, blood film, Usenease, and clotting. But really try and find the cause. So this could be something like DIC, disseminated intravascular coagulation, where you want to do a septic screen, drug history, cancer history, which can also trigger it, as I'll come on to, obstetric events, things like HELLP syndrome and so on. TTP, thrombotic thrombocytopenic purpura, this could be caused by deficiency in this enzyme called ADAMTS13. As well as, some other factors can contribute, like HIV and pregnancy, hemolytic uremic syndrome caused by E. coli 0157, which produces the Shiga toxin. So these patients typically have a preceding diarrheal illness beforehand, but we're going to come into these in a lot more detail in a second. So this is really for your revision. I'm not going to go through it because it's kind of covered everything that I have already mentioned, but this is kind of how we can think of breaking up hemolysis. The one thing that I don't really like about this picture is that it kind of shows intravascular and extravascular hemolysis as being two completely separate things. But the reality of a lot of this is that you can get overlap between these two things because things that cause intravascular hemolysis can result in extravascular hemolysis and vice versa. So you don't really want to spend too much of your time worrying about whether it's strictly intravascular or strictly extravascular. I think that's kind of a little bit a waste of your time, but knowing how the different things present and then what's the more likely predominant feature is perhaps more useful. Okay, so back to your normocytic anemias. We've talked about hemorrhage, we've talked about hemolysis. The other thing is anemia of chronic disease, which is a diagnosis of exclusion. So really, this is happening because you have iron unavailability, because you have increased hepcidin production in response to inflammation. So you might remember that hepcidin is basically produced in the liver, and it basically is inhibiting ferroportin, which is a transporter that basically makes your iron available in the bloodstream. So you will have iron stores, like your ferritin might be perfectly fine, but you just can't use the iron that you have. And there's a lot of different causes of this. It can be just chronic inflammatory conditions like IBD, for instance. It could be malignancy. You might have a chronic infection, chronic heart failure, and so on. And so really you want to try and treat the underlying cause because, supplementing with iron, for instance, is not going to help because it's not a deficiency problem, if that makes sense. So I think this table from Debbie's slides is really, really useful to try and interpret your iron studies. In reality, it's not always very simple, but the main things is that in anemia of iron deficiency, your serum iron will obviously be low. Your transferrin, which is transporting your iron around, will be raised because it's essentially trying to capture as much iron as it can, or it might be normal. And then your ferritin, which is your iron stores, will be low, or it might be normal. But if it's low, it basically proves it's diagnostic of iron deficiency anemia. Anemia of chronic disease, again, serum iron will be low, but because you don't want to utilize any iron, your transferrin levels will be low and your ferritin will be normal or perhaps even high because you've stored away all of your iron so that you can't use it. And this is, again, for your revision purposes. So how are you going to investigate anemia if you have a patient who comes in with low hemoglobin? You kind of want to start off checking their ferritin because that will give you such an easy way to fix the problem. And then you want to check, all of your other hematinics and so on. But you'll really be guided by their symptoms as well and their clinical history. And certainly in the exam, you'll get more information than just that. And this is just the information in a different way. Okay, so I thought I had a transition slide here, but anyway, that is all about anemia. That one is super high yield, so please do spend some time on that. With respect to the hematological malignancies, I feel like this is such a minefield for people. So I hope I'm going to break it down, but again, if it's confusing, please interrupt me if I'm going too fast. I think the main thing is that you can think of hematological malignancies as being either a leukemia or a lymphoma. And if it's a leukemia, we're saying it's cancer of the bone marrow. So this could be presenting with bone marrow failure, with systemic symptoms. And leukemia can be myeloid in origin or lymphoid in origin, and it can be either acute or chronic. So when we think of acute leukemias, we're thinking of things like AML, acute myeloid leukemia, ALL, acute lymphoblastic leukemia, and they develop really, really rapidly. And the main thing with an acute leukemic picture is you have a huge increase in the immature cells because you basically have a complete failure of maturation of your cells. So you get loads and loads of blasts entering the blood. If it's a chronic leukemia, this is like CML or a CLL. In this case, this is really, really slow presentation, quite insidious. Patients might be completely asymptomatic for a while. And what's happening is that over time, you're having an increase in the number of mature cells. So you're kind of getting an overproduction of those granulocytes or lymphocytes, depending if it's a myeloid or a lymphoid problem. And the main thing is that how are you going to distinguish? Well, really, what you want to do whenever you get a person who presents with blasts in the blood or an increase in mature cells in the blood, just immunophenotype those cells. So, i.e., send them to the lab for flow cytometry, and that's going to tell you, are they myeloid or are they lymphoid? Because we have really good markers for both of these cell lineages. So you can really easily distinguish that through immunophenotyping. And that's going to tell you, is it AML or is it ALL? Is it CML or is it CLL? So that's going to help you distinguish. The presentation's very, very similar, if not identical. So you do need that process. Then lymphoma is cancer of mature lymphocytes. So in this case, we're talking about things that are presenting as a lump or as a mass. And so things like, if you're presenting with an enlarged lymph node, that's a lymphoma, that's not a leukemia, typically speaking. And then you have this special type of lymphoma, which is, well, it can kind of be thought along the same side of things, which is myeloma. And that's when you have a cancer of your terminally differentiated lymphocytes, which are your plasma cells. And we'll come on to that in a moment. So let's kind of break it up into myeloid and lymphoid and go through those in turn. So the myeloid malignancies, you can think of them sort of as a spectrum. So we have something called myelodysplasia or myelodysplastic syndrome. At this point, we're talking about defective maturation of myeloid cells. And this means that they're morphologically dysplastic, i.e., the shape of those cells is really abnormal and you get a peripheral cytopenia. So clinical features, this is kind of something you see in older people. So this is a thing that's happening as you accumulate mutations in your hematopoietic stem cells and precursor cells throughout life. So it really is a condition of older people. You get gradual accumulation of mutations, and then you gradually get a decline in your blood counts. So hemoglobin, platelets, neutrophils, and essentially those blood counts will be reduced, but they're not going to be you're not going to have no mature cells because you have some maturation that's happening. It's just not as much as you normally have. So you will also see dysplastic cells, so these oddly shaped cells in the blood or the bone marrow. And the key things to look out for in a question stem is poor granulation of your neutrophils, so hypogranular cells, and variably shaped cells. And this is going to try and point you towards myelodysplasia. And essentially what you'll find is that dysplasia is present in more than 10% of the lineage. So that could be either the erythroid, the myeloid, or the megakaryocytic lineage, any of those ones. And ultimately, if left for long enough, it can progress to AML because it's a pre-leukemic condition. You can imagine if you end up with enough defective maturation, eventually all the maturation may stop as you get more and more mutations. And actually, in some schools of thought, it's thought that actually all of myelodysplasia will end up as AML. It's just that patients are so old by the time they're getting this accumulation of mutations that they end up dying of something else, if that makes sense. So patients typically die with myelodysplasia, not of myelodysplasia. But the key thing is that we need to monitor them because it's pre-leukemic. So acute myeloid leukemia is obviously once we've gone from defective maturation to a complete failure in maturation. So in this point, we have bone marrow failure and you have pancytopenia. So you have anemia, you don't have red blood cells. You have a thrombocytopenia because you have no platelets, and you have neutropenia, so you have low or no neutrophils. And that predisposes you to things like infections, bleeding, bruising, and so on. Patients will have a lot of constitutional symptoms. It progresses really rapidly, so they'll be complaining of weight loss and night sweats and fevers. You can get organ infiltration, so they will have enlarged livers and spleens. They can have inflamed gums and also infiltration of the skin, which is this leukemia cutis. It's kind of these bumps that you get on the skin. They might have bone pain, particularly things like sternal discomfort, aching in the extremities, because essentially you don't have enough red blood cells. And so you'll start to try and produce red blood cells in other parts of the body, so in the medullary cavity of these other bones, if that makes sense, where you wouldn't normally have it. And so essentially to investigate this, we're doing a blood count and we want to check the blood film because that's going to show us the increase in the blasts. So these blasts are the immature red blood cell or the immature myeloid cells, sorry. And what's happening is that there's so many of them building up in the bone marrow that they're kind of just spilling out into the blood. So you would never, never, never see a blast in the blood unless we're talking about myelodysplasia, where you might see a few, or leukemia, where you're going to see loads. Then what I said you can do is immunophenotyping because we need to know this is AML, not ALL. That's why we need that. So that's just going to be a test that you do on your blood sample. And then ultimately you confirm the diagnosis with bone marrow biopsy. And that biopsy should show that more than 20% of the aspirate or the trephine, normally do aspirate, is made up of blasts. And that's diagnostic of AML. The special case I just want to highlight is it's kind of a rare AML, so it's like 10% of AML cases. It's called acute promyelocytic leukemia, or APL. And the reason why this is important is because it's caused by a very specific chromosomal translocation, so T1517, and it produces this fusion protein called PML-RARA. The thing is that this leukemia is really, really extremely dangerous because it has these very, very hypergranular blasts. So the blast cells have tons and tons of procoagulant granules within their cytoplasm, and you'll see these Auer rods, which are these rods that you can see here in the cytoplasm, and those blasts are going to cause a huge amount of clotting within the vasculature. So you're going to get life-threatening hemorrhage with disseminated intravascular coagulation occurring. So, but the really cool thing about this type of leukemia is if you diagnose it, it's essentially very, very responsive to treatment, which is basically with an all-trans retinoic acid. So it's something that we can really easily treat once identified. But it's really important to diagnose. Then we have the myeloproliferative neoplasms. These are more chronic. So essentially group of disorders where you're getting an overproduction of one or more of your blood cell lineages in the bone marrow. So we're talking about either the red blood cells, the platelets, or indeed sort of any of those cells like your myeloid lineage as well. And what happens is that you end up with acquired genetic mutations that will start providing a proliferative advantage to the hematopoietic stem cells or progenitors within the bone marrow. And so it is a clonal process. So you're ending up with clones of cells that are producing more and more cells. And essentially, you can split it up into 4 different conditions, each of which has a molecular defect that's associated with it that produces splenomegaly. So all of these patients will have splenomegaly and will be presenting with a very chronic course. So it develops over a long period of time. And what we do is we split them into those that are BCR-ABL negative and those that are BCR-ABL positive. So BCR-ABL positive, if you hear BCR-ABL positive, that's automatically it's chronic myeloid leukemia, it's CML, and I'll come on to that in a second. But the negative ones are your polycythemia vera, essential thrombocythemia, and myelofibrosis. So I just created these tables for you guys to get all of the information that you need in a hopefully easy to revise format. But what you have is that if you have polycythemia vera, oh, I have something in the chat. Oh yes, I think there is going to be a recording that is released afterwards for people who have to go. I'm sorry, it's my fault because I'm late starting, but I believe the recordings will be made available. I just need to check whether it's either before or after the formative, which I'm not 100% sure, but you will get the slides as well if you fill in the feedback code. Hopefully somebody can share it with you. Yeah. Okay. So polycythemia vera is caused by overproduction of your red blood cells and soon. Okay, recordings will be uploaded before the formative. Polycythemia vera is caused by overproduction of red blood cells, which basically results in a lot of increased blood viscosity. So essentially you're going to have a lot of red blood cells circulating, and that means you're going to be very, very prone to things like blood clots, DVTs, PEs, that should say MI, CVAs, And you also will end up with being quite itchy, especially after a really warm bath. That's quite characteristic, migraines and just general fatigue. These patients, you obviously have raised hemoglobin, but the MCV will be normal. And the other thing is that the hematocrit, so that's the amount of sort of concentrated red blood cells, is going to be raised as well. And ultimately, what you want to do is you want to, first of all, check your erythropoietin level, because you can imagine if you have loads of red blood cells, that's going to be suppressed as a normal compensatory mechanism. And you want to do your bone marrow aspirate, which is going to help you see whether there's increased production of red cell precursors in the marrow. But ultimately, the diagnosis here is coming from genetic screening. So most of these patients are going to be having a mutation in JAK2 V617F. So you really should know that. If this is negative, you try and screen for JAK2 exon 12, which is just a slightly different mutation that will be present. So those are going to be the two main drivers. And when we're thinking of differential diagnoses, you always want to think, is this a true polycythemia, i.e., is there really more red blood cells circulating, or is it an apparent polycythemia, which basically means that your red blood cells seems like there's more red blood cells, but they're just more concentrated because the overall plasma volume is lower. So we're thinking of things that are secondary to things like dehydration, diuretics, alcohol, smoking, that sort of thing. And the true polycythemia, which could be there are increased red blood cells, but it's not because you have a direct mutation in the bone marrow driving it. It's rather because you have a lot of EPO, and that could be because you have an EPO-secreting tumor, for instance, in the kidney or elsewhere. Or maybe you have exogenous EPO, athletes who are using EPO, for athletic performance, which obviously is kind of illegal. But anyway, obviously this can transform to myelofibrosis or AML. So again, you want to watch out for this. And ultimately, these patients are managed with aspirin because of the increased risk of blood clot formation, also venesection, so literally just bleeding them. And then you can do cytoreductive therapy with things like interferon and hydroxycarbamide. Essential thrombocythemia is more about overproduction of platelets. So actually, this is something that's quite difficult to diagnose, I would say, because they're often asymptomatic. So you might not necessarily know that someone has ET, but they can present with things like bleeding and thromboses. And that the bleeding bit, I think, is harder to understand, but it's just because you're producing more platelets, but the platelets themselves are also a little bit dysfunctional. So even though you have more of them, they're not necessarily helping. So that's why you can get either or. And you would really think of trying to look for ET if you have this unexplained persistent platelet count that's more than 450 times 10 to the 9. So it's just raised. You can do a bone marrow aspirate. And then again, a lot of these patients will have JAK2 V617F mutations. The others will have mutations in things like calreticulin or the MPL receptor. And this is all in the same process. So the JAK2 pathway is basically downstream of EPO. So they're all kind of and TPO. So they're all kind of driving the process that way. So through the original pathway, if that makes sense. Differential diagnoses can be things like a reactive thrombocythemia. So you can actually get an increase in your platelets, often with infections or other things like that. With malignancies, it's actually very, very common to see a high platelet count with malignancies. So if you get a high platelet count, you also want to think about other kinds of cancers the patient may have, smoking as well. And again, this can transform to myelofibrosis or AML, and you can treat with aspirin and then cytoreductive therapy. Myelofibrosis is more about destructive bone marrow fibrosis. And this is really because you have, it's driven by the same mechanism. So it's typically through the cells having these mutations, JAK2, V617F, calreticulin, MPL. But in this case, what's happening is the megakaryocytes are kind of creating this, releasing a lot of cytokines and signals that are causing deposition of collagen fibers and reticulin fibers. And that means through stimulation of fibroblasts. So this can arise either de novo, or as you might imagine, it can arise secondary to PV or ET. So either of those things can happen first. And These patients are quite a bit more symptomatic, actually, because the problem is sort of in the bone marrow itself. So they'll have B symptoms, those night sweats, fever, weight loss, early satiety, itching. They'll have a distended abdomen. They might have low hemoglobin, low white cell count, low platelets on the full blood count. And what you need to know is that the blood film will show something called a leukoerythroblastic change with teardrop erythrocytes. So what does that mean? It just means you have a shift to like a left shift in your neutrophils and granulocytes. So you have a lot more immature cells. There is basically the nucleus and the cytoplasm are kind of maturing at different rates, and then you get these teardrop red blood cells because they're getting squeezed out of the bone marrow through all of this fibrosed tissue. So they're really just like creating an abnormal shape. But if you just know these words, just think myelofibrosis. And again, this can transform to AML, and you treat these patients with this drug called ruxolitinib. Oops. Okay, so BCR-ABL positive neoplasms are things like your chronic myeloid leukemia. This is a massive excess of both mature and maturing granulocytes, plus their precursors in the blood. So we're not really talking about this. You're going to see a ton of cells, a ton of granulocytes when you look at the blood itself. And actually, this can essentially this might be detected within your white cell count. So your white cell count might be sky high, but actually it's just all of these like mature and maturing granulocytes. Not all of them are going to be fully functional yet. It's caused by this translocation between chromosomes 9 and 22. So that's called the Philadelphia chromosome, and that gives rise to BCR-ABL, the BCR-ABL gene. Patients are presenting with weakness, fatigue, weight loss. They have a lot of abdominal discomfort because they get a lot of splenomegaly happening. The white blood cell count is going to be really, really high. On the blood film, you're going to see all of these granulocytes, and you're going to see that they are not going to be properly mature. You can do PCR to look for the fusion gene itself, and then you can also do karyotyping or this fluorescence in situ hybridization for the Philadelphia chromosome. So those are going to be your two diagnostic tests, and you ultimately can manage this with tyrosine kinase inhibitors like imatinib. But this is obviously, these chronic conditions are not really curative. They're more like managed in the longer term, if that makes sense. Then lymphoid malignancies, I think these are somehow perhaps a bit more confusing because there's so many different categories. But the key thing is that, is there a lymphocytosis in your blood films, in your blood or your blood film? And if yes, you want to do immunophenotyping with flow cytometry because it's going to tell you where those cells are coming from. If there's no lymphocytosis in the blood, then you're really going to have to biopsy the lymph node or the mass because that's going to be the way to diagnose it. So those are the two kind of ways, because lymphoid can be lymphoma or it can be leukemia. So starting with ALL, this is really a leukemia. So again, as I said, leukemia always means failure of maturation, but in this case, it's of lymphoid lineages. So we're talking about B and T lymphoid blasts. The blasts then accumulate in the bone marrow, which would be a lymphoblastic leukemia, or they can accumulate in a mass, which would be a lymphoblastic lymphoma. So mass, lymphoma, bone marrow accumulation is leukemia. It's the most common childhood cancer, and you often find it within like very young girls and boys, 1 to 9 years of age. It'll be a pancytopenia. They'll present with a bone pain, and a limping child. This would be very one of your differentials for sure, non-specifically unwell. And then you'd have sort of a pancytopenia on your blood count. Your blood film will show loads and loads of blasts. And again, you can do immunophenotyping and a bone marrow aspirate. And ultimately, this is managed with quite a significant chemo regime, 2 years for girls and 3 years for boys. But it does have a fairly good prognosis after that. Chronic lymphoblastic leukemia is the most common adult leukemia. And it's often incidental. So patients might have B symptoms. They might have, enlarged lymph nodes and enlarged spleen, but otherwise, fairly low-level symptoms. What you'll see is that on the blood film, you get these small mature lymphocytes and smear cells. I think this confuses people. The smear cells are not a feature of the fact that they're actually like that in the blood. It's that they're so fragile because they're not quite normal cells. There's just so many of them and they're not all normal. So when you're actually preparing the slide, it creates like a smear, like the blood cell kind of the lymphocyte kind of deforms essentially. So that's why you get these smear cells. And you can also do FISH and look for this deletion of chromosome 11q. So these patients are at risk of increased infection, especially with encapsulated bacteria, because their white cells are not functioning that well, and also those autoimmune complications like ITP or autoimmune hemolytic anemia. And you can also get something like a nodal version of CLL, which is basically when you have pretty much this picture, but it's presenting as a lump, and that's going to be SLL. So that's kind of within the lymph node, but that's very small print. Okay, so lymphoproliferative neoplasms, this is when you have excess lymphocytes, and this is occurring sort of outside of the bone predominantly. So this is when we're thinking more of our lymphomas. So the way to think about the lymphomas is just think in your head, is it high grade or low grade? Has it developed quickly or has it developed slowly? So if it's developed quickly, we're thinking of Hodgkin's lymphoma and the other high grade non-Hodgkin's lymphomas. So if it's developed quickly, it might be Hodgkin's lymphoma, which would be common if they're around 15 to 35. They have this rapidly growing lump and they say, oh, it's really painful after I go out drinking with some friends because it has alcohol-induced pain. If it's really itchy and they have a lot of B symptoms. This is associated with EBV infection. And the key thing you're going to find is when you biopsy, which has to be either excisional or core biopsy, not a fine needle aspirate. When you take a biopsy of that lymph node, you're going to see binucleate Reed-Sternberg cells. And these are on an inflammatory background. There's actually very, very few Reed-Sternberg cells. They're just kind of scattered in between, which is why you have to take a whole biopsy. You stage this with the Ann Arbor staging process, which is basically, how many sites you have affected above and below the diaphragm and so on. And you can treat with combination chemo and radiotherapy. Burkitt's lymphoma is the most high grade of all human malignancies. It's got like 100% proliferation index. It's really crazy. The cells are really, really dividing fast. It's associated with both EBV and malaria. And characteristically on biopsy, you see a starry sky appearance because you have these macrophages that are embedded in this really monomorphic lymphoid infiltrate. And you just get these kind of punched out areas that are the starry sky from the apoptosis that's occurring. So this is a balanced translocation between chromosome 8 and 14, and due to placing c-Myc under the IGH enhancer. For this one, the main thing to be aware of is tumor lysis syndrome. So it responds amazingly to chemotherapy. But because of that, you're really at risk of tumor lysis syndrome because the cells are really melting away and all dying, and they release all of their contents into the bloodstream. So you probably covered this in your biochemistry lecture. But yeah, that is the one main thing. It's just like high potassium, high phosphate, and so on that you're going to be having to monitor. Diffuse large B-cell lymphoma is actually the most common lymphoma and increases in incidence with age. So these patients have B symptoms, early satiety, predominantly from that enlarged spleen. HIV is your risk factor here, and here you get this infiltration of these large pleomorphic lymphoid cells, so those B cells, and they stain positive for CD20, the B cell marker. And again, you can treat with combination chemo and rituximab, which is your anti-CD20. So if the progress is more slow, then you're going to be thinking more of your low-grade lymphoproliferative disorders, and this is going to be divided into these are a bit more difficult, I would say, to remember, but they're also tested a bit less, I would say. So you have follicular lymphoma, which commonly presents around like in the 60s, sort of older age, often asymptomatic, or maybe they have lymphadenopathy, but it's really painless. On biopsy, you're going to see a lot of closely packed follicles, and they have centrocytes and centroblasts. So those are the main keywords there. Typically caused by overexpression of this anti-apoptotic BCL2. And really, you only need to treat them if they're symptomatic. And otherwise, it might transform to a high-grade diffuse large B-cell lymphoma, which is the main reason to keep an eye on it. You also have something called Waldenstrom's macroglobulinemia or lymphoplasmacytic lymphoma. So in this case, these patients were going to have this cryoglobulinemia. So you often have almost like a Raynaud's phenomenon because they get a lot of uh, red cell agglutination in their peripheries, kind of like cold autoimmune hemolytic anemia. They'll have hypoviscosity syndrome symptoms, and it will also be mostly driven by IgM paraprotein. That's why I compare it to cold autoimmune hemolytic anemia, because it's also this pentameric antibody that's driving the process. And you're going to see this on your serum electrophoresis. There's an association with hepatitis C as well, which you might need to know. But ultimately, on bone marrow biopsy, you find this infiltration of these lymphoplasmacytoid cells. So this is kind of on a spectrum almost with myeloma. It's very, very similar to myeloma, but just a little bit different because it's driven by IgM. So yeah, that's kind of the main thing. Again, not all patients are going to require treatment originally. And then multiple lymphoma is the lymphoma of your mucosal tissues. So this can be in any mucosal tissue. So the stomach is a really common site because it be driven by H. pylori, also the salivary glands if you have Sjogren's syndrome, Hashimoto, so the thyroid as well. And ultimately, you can just excise this. It's very, very low grade and eradicate H. pylori if it's present. Oh, okay, we're getting there. All right. So myeloma is a malignancy of your plasma cells, which are those terminally differentiated antibody-producing B cells. The plasma cells, once they have been made, are actually living in the marrow, which is why it's a disease of the bone marrow. And essentially, you can think of it as being on a spectrum. So we start off with MGUS, which is monoclonal gammopathy of undetermined significance. This means you have a bunch of plasma cells, they're abnormal, they're a clone, so they're all identical. They're producing a paraprotein, but it's causing no symptoms. So everything's fine. It's just they have a clone of plasma cells. Then it becomes smoldering myeloma, which is like MGUS, but now that clone is big enough for us to say it's now smoldering. There's still no symptoms. But this means there's more than 10% plasma cells in the marrow or the paraprotein or, so it can be either one of these, the paraprotein is more than 30 grams per liter. Then once you get to myeloma, this is when you have a clone of plasma cells that's causing clinical problems. And that includes either one or more CRAB features. So it can be hypercalcemia, renal impairment, anemia, bony disease. So like osteolytic bony disease, we get back pain because you have pathological fractures from all of the bone destruction. And you might also be at increased risk of infection because of reduced production of your normal antibodies. But the key thing to note with the CRAB feature is that the CRAB feature must be a direct result of the clone of plasma cells, which can be kind of difficult to unpick. So you might have hypercalcemia, but it might not be because of the clone of plasma cells. So you just need to be aware of that. So investigations, serum electrophoresis is going to be your main thing because you want to look for your paraprotein. And you can also do your bone marrow aspirate to see that increase in your plasma cells as well. You'll also see an imbalance in your proportion of free light chains. So the kappa and lambda, those light chains on the antibody molecules, they're normally present at a ratio of 2 to 1 in the serum, but this will be distorted depending on whether it's a kappa or lambda predominant that's being produced. And in your urine, you might find something called Bence-Jones protein, which are basically this paraprotein being found in the urine itself. And if you look at a blood film, you'll get something called rouleau formation, which is when the red blood cells all kind of stack on top of each other and look like a big cylinder, if that makes sense. So this is just kind of to try and help you narrow down your differentials from your question stems. And that's everything with malignancy. So I hope it was understandable, or at least will be once you have a look at the slides. The last part, I think, is fairly short. It's more on bleeding and clotting. I would say we don't really need to know that much about the pathophysiology of the clotting cascade or anything like that. You might recall that clotting is split into primary and secondary hemostasis. So primary is when you form the platelet plug, and that requires von Willebrand factor. And then secondary is when you form the fibrin clot, which stabilizes the platelet plug. So this is kind of through your clotting cascade, which I think people have a love-hate relationship with. I personally really like the clotting cascade because I think it makes a lot of sense. But the main thing is that on the red arrows are all the extrinsic pathway, which you can test with your prothrombin time clotting test. So it's tissue factor binding to factor 7, and then that activates factor 10, which activates factor 2, which activates factor 1, so fibrinogen to fibrin. And this is just your initial clot. So prothrombin time is really, really quick. It's you only measure it for a certain period of time so that you're only measuring this part of the pathway. But the extrinsic pathway ultimately activates the intrinsic pathway, which is tested kind of artificially with activated partial thromboplastin time. I say artificially because it uses factor 12, which is not actually in this normal intrinsic pathway. We don't think anyway from the research, but essentially factor 2, the way that this works is once you have thrombin, which is activated factor 2, you'll activate factor 8 and factor 9, and then that will allow you to, and 11, that will allow you to activate factor 9. And then ultimately, together with factor 8, you activate factor 10 and it feeds back. So it's just sort of a reinforcing loop. The main thing to take from this is that you need to know which factors you're testing when you test the prothrombin and the activated partial thromboplastin time, because that's going to tell you where the problem is when you interpret the results. So in terms of bleeding disorders, these can be inherited or acquired, basically. If it's inherited, you're thinking of your hemophilias, which are X-linked deficiencies, or things like von Willebrand disease, which is often, though not always, autosomal dominant in origin. If it's acquired, you can think of things like multiple factor deficiencies caused by a DIC picture, major hemorrhage, liver disease, lack of vitamin K, so specifically hemorrhagic disease of the newborn, which is basically caused by the fact that the newborn, the fetus, has very, very, very low vitamin K stores, and there's not much transfer of vitamin K through breast milk and things like this. So the newborn is at very high risk of having vitamin K deficiency. And if they don't receive vitamin K sort of prophylactically at birth, then they may develop hemorrhagic disease. Also, you might just be on anticoagulants, or you might be receiving fibrinolytic therapy. So I would say this is something to just kind of go over in your own time. I think a lot of people probably know the anticoagulants quite well. The main things are just that if you're using warfarin, which really we don't do that often anymore, except if a patient has a mechanical heart valve, for instance, then what you need to know is it's going to increase your prothrombin time in INR. And ultimately, if you need to reverse it because the patient has a major bleed, you want to give them vitamin K plus or minus the prothrombin complex concentrate, which contains those factors, the vitamin K dependent factors, so 2, 7, 2, 7, 9, and 10, I think it is. And then your DOACs are essentially dabigatran, your direct factor 2A inhibitor, and your direct factor 10A inhibitors, apixaban, rivaroxaban, edoxaban. I think you guys probably know this already, but factor 2 bi, so dabigatran, that's how you know it's a factor 2. 10A has XA in all of the names, apixaban, rivaroxaban, edoxaban. So that's just how you remember the mechanism. And you can reverse them. They have their own reversal agents, iduricizumab, which is a antibody, and andexanet alpha, which we can only really use if there's a GI bleed, unless it's used off license. And then you have your different types of heparin, which the main thing to say is that heparin is great. If you use unfractionated heparin, you basically have to give it via continuous infusion. But the good news is that you can really easily reverse it, and it has a very short half-life. Whereas the low molecular weight heparins are much safer and much easier to use, but they're only partially reversible. So you might just want to bear that in mind. Then the platelet disorders. So the platelet disorders basically can be split into these 5 different conditions. These are the ones you really need to know. I would say immune thrombocytopenia. This is what you're going to think of when you have a patient who basically only has a low platelet count and everything else is normal. Tends to be pretty idiopathic or caused by an autoimmune destruction of platelets. And ultimately, if it's happening in a child, the child almost always just spontaneously recovers. But in adults, if that platelet count falls below a certain level, you need to be treating them with steroids, so prednisolone. But otherwise, it's fairly okay. Then DIC, this is when you have disseminated intravascular coagulation. So you have basically widespread activation of your clotting cascade, and that can be through many different things. Could be sepsis, it could be a malignancy, so specifically prostate cancer, which is really procoagulant. as well as acute promyelocytic leukemia, which I mentioned earlier, that produces all those procoagulant granules. So that can all trigger disseminated intravascular coagulation. And this is a type of MAHA, so it's a type of microangiopathic hemolytic anemia. So the main thing to bear in mind with DIC suspected in a patient where all the clotting factors are deranged, so you have prolonged PT, prolonged APTT, you have low fibrinogen because just low platelets, everything's just being consumed. And ultimately, you need to try and stabilize the patient, treat the cause, the underlying cause, and you might need to give them clotting factors as well. TTP, thrombotic thrombocytopenia. This is a typo. I'll fix this in the slides. Thrombocytopenic purpura. So basically, this is caused by a deficiency in this enzyme called ADAMTS13, which is basically chopping up your von Willebrand factor into lots of little pieces. So essentially, when it's not present, von Willebrand factor is really long, and it essentially activates loads of different platelets and things within the circulation. And so essentially you end up consuming all your platelets. So the platelet count will be low, but everything else is actually fine. They have a normal PT, they have a normal APTT, but they're really, really unwell. And notably, they'll have things like neurological signs, renal failure, and so on. So these patients really need to be, this is actually one of the top ones you always, always need to rule out because it will kill the patient. So you need to think about this whenever you are considering a MAHA. And you'll have schistocytes in the blood film with all of these. Hemolytic uremic syndrome is kind of like, it's actually very similar to TTP. It's quite difficult to distinguish because you have similar signs and symptoms, but the main, except that you don't have neurological signs. But the main thing is that this is driven by a Shiga toxin producing E. coli 0157, and they'll have very similar presenting signs, but in this case, you will find that they have no neurological signs, but they do have schistocytes and they have everything else that the patients with TTP have. So you often have to rule out TTP first. Kids with this tend to do fairly okay as well, but ultimately the management, supportive care, and then maybe dialysis if they have very significant renal failure. And finally, heparin-induced thrombocytopenia. This is basically in patients who have heparin and then, a couple days later, 5 to 10 days later, they develop a low platelet count. So this is kind of because you produce these antibodies that are against this heparin platelet factor 4 complex. So that's really what you're looking for. So you can just directly test for those anti-platelet factor 4 antibodies. Okay, so I feel like that was just about an hour and a half. So we do have time for some questions if people are still here and still willing to take part. So yeah, please do log on. I will try and figure out how I can fix this. I hope that it's working. Do you guys still need sorry, I'll just go back to the slide so you can see the QR code if you need it still. Hmm. Okay, I think everyone is here. Hopefully you can see my screen. So, yes, great. So this answer in this case was pernicious anemia. Hopefully you guys can see the answers as well. Please let me know if there's any issues accessing it. So the main thing is obviously it could be due to a vegan diet. So this person's not totally wrong, but in this case, the patient reports eating a balanced diet. So pernicious anemia would be our top differential in this case. And also the other thing to note that you could pick out in this question stem for exam technique purposes is that patient also has type 1 diabetes. So that's not entirely, it doesn't always happen that they also have pernicious anemia, but it can be. So yeah, they can happen together. Okay, so for the next one. Okay, so for this one, the answer is B12 deficiency. So in this case, what we have is an anemic picture that's macrocytic, which I think you guys mostly picked out on. The key things that tell you it's B12 deficiency. So patient is presenting with fatigue, which is really common of all anemias, but then has pins and needles in the hands and feet. So this is screaming out like peripheral neuropathy. It has like paresthesia. So it's these symptoms that are really making you think it's definitely B12. And the other thing that is here is that the patient's also using nitrous oxide. So remember, I said nitrous oxide basically causes B12 deficiency as well. So that's one of the key causes. So that's why the answer is B12, although folate would also cause a macrocytic anemia picture. So yeah. This is sort of the mechanism. So the nitrous oxide inactivates B12 by oxidizing the cobalt ion in cobalamin. So that's how it causes a functional deficiency for those who are interested. All right, question 3. Okay. So I think this one's a bit more tricky. So basically, this is just talking about pattern recognition, about these histological, like morphological things. So the idea is that you have a lymphocytosis. So you automatically are thinking this must be a leukemia. Why? Because this is obviously within the blood. So lymphocytosis means you have increased number of lymphocytes in the blood. So if it's in the blood, we're thinking leukemia rather than a lymphoma. And if you have a smudge or smear cells, you might remember I said when you do the blood film with a chronic lymphoid leukemia, those cells are quite fragile, and so they essentially can end up causing these smudge or smear cells. For the person the people who've put proliferation of T cells. So most of the lymphomas that we have been discussing in LabMed are typically B cells. I think this is quite a mean question. I actually don't know if they would necessarily put these as two options in the exam. But we're not really talking that much about T cells, although they can cause lymphomas and so on, but it's just much less common. So that's why we're all of the teachings really around B cells as the cell of origin. Okay. If anything's unclear, like please do ask me. Okay. Perfect. So yeah, so this is an acute hemolytic transfusion reaction. I will share with you guys a table. I realized it wasn't in the slides, but I will share a table with the different transfusion reactions that can occur. Acute transfusion reactions are the ones that are typically caused by donor incompatibility. So this is a never event, obviously in the hospital because of cross-match and things like that. So this should never really occur. But if it were to occur, you're going to find that patients present like this. So hypertension, fever, and they can have both abdominal or chest pain. So this is kind of an immediate reaction. Amazing. Yeah. So I hope this one is drilled into your brains. Reed-Sternberg cell is always Hodgkin's lymphoma. The other things that you can just pick out from this stem, 32, so right in that age group, 15 to 35, has fatigue and just general constitutional symptoms. Of course, the lymphadenopathy is non-tender, but what would be nice is if they'd mentioned something about the alcohol, pain on alcohol consumption. That's the other feature to watch out for. So yeah. And those are binucleate cells. I think sometimes like owl's eye or something. That's how they otherwise refer to them in a stem. Okay, so I think this question again is a little bit mean because there's really two answers that I think would be almost okay here. So intravascular hemolysis is the one we're looking for. The other one that I thought guys might go for is the MAHA. So let me just explain the difference between the two. So intravascular hemolysis is obviously when the blood cells are being broken up in the bloodstream. So they're definitely going to have schistocytes, the red cell fragments within the blood film. Maha also has schistocytes, so that's why it is a other key differential. Extravascular hemolysis will typically have spherocytes because the splenic macrophages are taking the chunk out the membrane, and so it loses its normal morphology and springs up into a sort of more sphere like morphology. The reason they're looking for schistocytes here is really to do with the mechanical mitral valve replacement, which points towards this being a mechanical hemolytic anemia picture. So that is clearly just you're breaking up those red blood cells as they're passing through the mitral valve in the circulation. So that's why it is intravascular hemolysis. It could theoretically also be alternatively be a MAHA, but I think because they've added this here, the mechanical hemolysis is much more likely. And if they were going for a MAHA, you might expect them to be much more sick in terms of multi-organ failure and so on. Okay, just a couple more to go. This should be a quick one, I hope. Okay, yeah, so perfect. So we're talking about the prothrombin time here. So I've kind of just put an explanation for the different clotting tests but that you can do. But essentially, prothrombin time is measuring the extrinsic pathway. So that's, tissue factor binding to factor 7, activating factor 10, activating factor 2, activating factor 1. So yeah, that's going to be your extrinsic. The activated partial thromboplastin time is going to be measuring the intrinsic pathway of coagulation, which is the one that gets activated by the extrinsic pathway, normally in the body. So yeah, I think this is just a case of knowing your anticoagulants. Exactly, it is a direct inhibitor of thrombin, which is factor 2. So remember I said that you can always tell with the DOACs which one does what by looking at what's contained in the word. So dabigatran has bi as in 2, which means it is inhibiting factor 2 or factor 2A rather, which is thrombin. And the factor 10A inhibitors are often used. I would say if you're in the hospital, you will see that the 10A inhibitors are more frequently used in this situation, apixaban and so on. But nonetheless, they asked about the dabigatran here, so that's why it's a direct inhibitor of thrombin. And yeah, perfect. Final question. So this is actually I got a lot of my questions from PassMed if you guys are interested, but this question specifically is the kind of thing that comes up every single time in the LabMed MCQs. It's very classical. They always ask about the serum electrophoresis for thalassemia. So the answer is beta thal trait. So I would advise you to go back to the table that I made with the different types of thalassemia. But let's go through why it's thal trait. So what we know about her is that obviously she has signs of anemia, fine, and she has a blood disorder that runs in the family. Okay. She's also from Greece, so sort of Mediterranean. This is quite a classical place to find beta thal. She also says she's never had a blood transfusion, which automatically means that we can exclude beta thal major because beta thal major, they will have to have blood transfusions because they don't have any normal um, uh, beta globin. I can see why somebody might have put this here because they didn't give the rest of the electrophoresis findings. So there will be some normal HbA as well that would be there. So the fact that it's raised HbA2 doesn't exclude the fact that normal HbA might also be there. I know that's confusing, but never had a blood transfusion means it can't be major. And so then we're left with the other options. So let's go through that. Very, very microcytic. Okay, this means that we're automatically thinking it's thalassemia. So A to D, that rules out sickle cell, which tends to be a normocytic picture. So that's fine. And then ultimately, the diagnosis comes from raised HbA2. So this is alpha 2, delta 2, normal hemoglobin, alpha 2, beta 2. If we have a rise in alpha 2, delta 2, this means that it must be because we have alpha, but we don't have enough beta. So that means it can't be alpha thal trait and it can't be HBH disease, both of which are driven by a deficiency in alpha because we have no problem with alpha. It's there, it's being used. So the problem is with the beta globin chain being deficient and being replaced with delta, causing raised HbA2. So that's what makes the answer beta thal trait. I hope that makes sense. But yeah, if anyone has any questions, let me know. Yeah, that is all of the questions that I have. Can you guys see my QR code? Hopefully, I'll just share it here. If you could just fill in this feedback form to get the slides, and also I would really appreciate your feedback. I think I'm giving one of the other revision lectures, so based on what you guys say, I will amend my teaching in accordance with what you say so that it's most helpful for you guys. So please do let me know. Thank you so much for coming, and I hope it was useful. Good luck in your exams.